My fifth lesson is that we may not like to think in terms of money. I heard on the radio this morning the chairman of the consultants committee of the BMA saying, it is immoral to make a change within healthcare simply to save money. You can only make changes if you're going to improve outcomes for patients. Unfortunately, I think we do have to think about money, and we have to pay very close attention to costs and the benefits that are delivered. And again, I think this is returning to the kind of utilitarian roots of public health. There's a slide that always sticks in my mind. It's hard to see this kind of slide for Britain, but because of all the data available in the US, you can see this kind of slide. I mean, each of those each of those dots is an institution. Actually, this is a state, not an institution, but you could see the same for institutions. And along the bottom is the spend per person within the state, and at the side is a measure of quality. And as you look at the slide, you can see that often there is very little relationship. So I think the idea that more money equals more quality, more benefit is simply wrong within healthcare, and we need to emphasize that point. Here's some data on the cost effectiveness of different kind of interventions for chronic disease for low and middle income countries. Comes from Tom Gaziano, one of the people we're working with on our program. And you can see there very considerable variation from simply giving people aspirins after infarcts, which is probably cost saving, through to a cabbage, a bypass operation, which is producing $27,000 per disability adjusted life year. And here's some data on different kinds of interventions to reduce cardiovascular risk. And you can see that salt reduction, something I know that people talk about and think about a lot here in Australia, is extremely cost effective. Secondary prevention also can be cost effective. But I think we do need, is my argument, to think very hard about what is the value we're getting for various interventions. And I think somehow it's easier for public health people to do that than it is for clinicians.